I know how tight money is, but I know how valuable education is. So I'm here, and we're going to talk. You think, Sean, we can just maybe dim the lights up here a little bit? My request is recorded, so we can't say I never asked. So today what we're going to do is we're not going to talk about airway, but we talked about airway for the last couple of weeks. And what we're going to do today is talk about what happens in trauma and traumatic injury, whether it's coagulopathy, whether it's fibrinolysis. We're going to talk a lot about coagulation, but we're going to kind of stay on top of the water. We're not going to dive too deep here because it's late and this could go on for, this could be a 6-hour talk if we really wanted to, but we don't. So we're going to talk about when physiology changes. What happens at the time of a traumatic injury? What's happening out there right now in 695 to whoever's injured at the time of the injury? Before help even arrives, there's an ongoing process. And it's to varying degrees that occurs. You're also going to see a lot of military references here. I work with Special Ops Medical Support for NATO. So we're going to talk a little bit about that kind of partnership and how it affects all of us in the civilian world as well. So it's about when physiology changes. And again, every day is Veterans Day for me. Never forget any sacrifices that all these men and women have given us throughout the years and continue to do so. So what are we in for? We're going to talk about patient profiles. Different patients in varying degrees of traumatic shock or traumatic injury before they go into shock and how we get them out of shock. We're going to talk about coagulopathy, both acute traumatic coagulopathy and trauma-induced coagulopathy. Two different concepts. Predictors of massive transfusion. What patients need blood, what patients don't need blood. And if they do need blood, do they need red blood cells? Do they need component therapy? Do they need red blood cells, fresh frozen plasma, platelets, fibrinogen as in cryoprecipitate? And when will we see a transition to whole blood use in the civilian population? Believe it or not, it's not too far off. I have some very dear friends down at Brooke Army Medical Center at the Institute of Surgical Research, and they're working very hard at being able, and we'll talk about what needs to be done to get us whole blood. A little bit about damage control. We'll talk about TXA, tranexamic acid, and how it's being used pre-hospital. And if I think we'll be seeing it pre-hospital in all the units. Resus management and conclusion. So we're going to kind of blend all this together. And we're going to jump around. So let's talk about traumatic injury. So light is red. Okay, so that guy did recover. However, if you look at his vectors of injury, they were circumference 360-degree vectors of injury. So he probably has multiple injuries. He had a lot of ortho spine, some soft tissue, but he had that vector of injury should have at least a torn aorta as one of his injuries, but he didn't. He actually, if I continue to play this, he actually sat up after a while. So he was probably drunk enough to be okay. So we define shock as what? So that guy, you think, at the time of his injury, before he even hit the ground, started to develop some form of shock. His physiology changed at the point of traumatic injury. So we talked about shock. What's the definition? Okay, so that's a good broad general definition of shock. What happens at the tissue level? What aren't we delivering? Oxygen, right? And what else do we need? What do you guys take a finger stick up? There's a reason for that. Not just so you can give D50 or insulin. There's a reason, right? If our glucose is low, we can't supply that machine. We can't supply the tricarboxylic acid cycle and make 38 ATPs, which runs the sympathetic nervous system, basically. So we talked about that last week, right? When we're anaerobic, we make 2 ATP. When we're aerobic, we make 38. So it's really important. So delivering that oxygen. But now we talked about oxygenation last week. What are we going to talk about now? We're going to talk about loading it and delivering it. Yeah? We know how to oxygenate patients. But part of resuscitation is actually getting it to at the cellular level. And we talked about it. Really, It is the cardiovascular system's inability to deliver oxygen and metabolic substrates, primarily glucose, to sustain aerobic metabolism. There was a guy who kind of started all this stuff in Maryland a while back. He was a cardiovascular surgeon. And what Cowley did was he had something called the death lab. If any of you visit, right, shock trauma, I'm going to shut this off. That's good for, actually, this is good for 2.3 hours of just continual use, if you want to look at it later. When you visit shock trauma, you come out of the elevators, there are red tiles down the middle of the floor and off to the true. Those red tiles are there to show you how to get to the true and how to get back to the elevators, but they're of historical purpose. It's the bloodline. It's how you found Cowley's death lab when he was back off the loading dock in the original building. He watched people die. And then he started resuscitating them slowly. Now, these are people that didn't expect to survive. And what he noticed and what he defined traumatic injury as is that people don't die from accidents or heart attacks, right? Not directly. They die from shock. Shock, think of it as a pause in the act of dying. And that's really critical in terms of treatment of traumatic injury. The pause is what we're going for. The pause is the tipping point between life and death, between anaerobic and aerobic metabolism, or aerobic and anaerobic. If we can prolong that pause long enough to create an aerobic metabolism, those patients don't die, and he found this out. So that gave rise to a unit that he resuscitated in. And then it went from just all kinds of shock to trauma. So it became his original and trauma resuscitation unit. That's where it is. That's where it leads, that red tile. So that's where it all started. So when you go there, you're really walking down a hallway of history as it applies to resuscitation. So let's talk about resuscitation. Supply and demand, right? Supply is supposed to outweigh demand. Absolutely. The more supply outweighs demand, the more reserve we have. But in resuscitation, we don't want to keep resuscitating because we can over-resuscitate. So we have to know when to pull back the reins. So supply versus demand, or aerobic versus anaerobic. The anaerobic part is a demand, aerobic portion is a supply. And guess what? It's time dependent. The faster we get there, the faster we create this gradient back, the state back to aerobic metabolism, the higher the survival rate, the lower the mortality. So let's look at 4 groups of patients that we see maybe on a daily basis. You know, we see them in our hospitals, we saw them in trauma, you'll see them on the road. And they're patients, let's look at the first group. There's anaerobic, aerobic, right? So the red is oxygenated, this is kind of like a bluish dark, you don't want to be down there. So these are patients who, they compensate for shock. We all compensate for shock tremendously. How do we do that? How do we get more volume? Well, we have 2 types of volume, stressed and unstressed. Our stress volume is what we're using right now in our circulation. Our unstressed volume is in reservoirs, venous reservoirs, all the capacitance reservoirs. Right? So when I do that, I just cause stress volume to be released because you just gave me a jolt of alpha-1 adrenergic stimulation, and you dumped because now your pulse is up, your heart rate is up, and I know your metabolism is up because you're red. You want to be able to do that. So I'm not embarrassing you. You are a physiologic model for us right now. So what did I do? I just created an increase in cardiac output by alpha-1 adrenergic stimulation. He created more central volume. So we just went from non-stress to stress volume. So your cardiac output is up right now. Now, if I kept going at you and I had a gun, you'd be out that door with a really high cardiac output and rate, right? So that's where we get that sympathetic inflow, that sympathetic influence in our maintaining circulation. So we compensate. We compensate really well. We can tap into volume. But what about, I won't do it again, I promise. So what about hemostasis? Can we achieve intrinsic hemostasis? Absolutely. Factor 8 has to be depleted 80% before we bleed. We have platelets hanging onto the walls in our spleens. We have calcium in our marrow that we can mobilize, because calcium is a cofactor in a lot of the coagulation cascade, which we're going to look at in a little bit. So we can draw all the stuff from all over. We can produce more thrombin. Thrombin is what makes us clot. Thrombin is what makes us die from vascular, thrombotic events like pulmonary embolus. So thrombin is really important. Thrombin and platelets, we either want more or we want to inhibit them. That's what coagulation comes down to, basically, overall. So if you look at all the drugs out there that we're giving, we're inhibiting vitamin K reductase with Coumadin. We're kind of blocking the arachidonic acid receptors of platelets with aspirin. We have Plavix. We got the ADP receptors. So we're always attacking platelets. And now we have the DOACs, right? The Bigatran, Rivaroxaban, Apixaban, right? Xarelto, Eliquis, all those drugs. That they're either anti-10A or they inhibit thrombin, right? Xarelto inhibits thrombin, the other two inhibit 10A. So we're all looking at the production of thrombin, whether we need it to clot or not. So we have this ability to achieve intrinsic hemostasis. So this is Granny, who you find down the bottom of the steps after like 36 hours. The family calls, she's not there, she's living by herself. She does all this stuff. You get her back, they give her a liter or two of volume, she comes around a little bit, they get her back to the assisted living, where they try to coax her into going to assisted living. My dad's 87 years old, he still lives by himself in the row house in Trenton, New Jersey that I grew up in, that I was raised in. Let me correct you, I never really grew up. That's what my wife says. So, we resuscitate. We auto-resuscitate. What about this group of patients? You can see they dip below the line. Again, they're anaerobic to aerobic, and it's time dependent. The faster we convert them, the better. Now, they compensate just like Granny did. But now, time has passed. So they decompensate. They can't keep up with the trauma, the traumatic injury, especially blunt trauma, right? A higher dose of shock for a longer period of time. What happens? Well, hemostasis isn't achieved. We help them here. They come in, they're decompensated. So what's that picture look like? They're hypothermic, they're acidotic, right? They're coagulopathic. So we have to reverse all that stuff. And we'll look at how that affects each part of this. So we help them achieve hemostasis. How? Well, we resuscitate them, and we really have predictors to tell. What do we resuscitate them with? Do we give them a couple liters of crystalloid? Do we give them some plasma albumin? Or do we give them red cells FFP? Do we kind of build that whole blood model, right? Can we put that together in component therapy? Which, as you know, if you treated patients or have seen them resuscitated, it's called high ratio resuscitation. 1 red to 1 yellow to 1 platelet, bag of platelets to 1 cryo. So we try to really mimic whole blood. We really need whole blood. There's some things missing there. But that's what we're trying to do. Remember we talked about over-resuscitation. If we over-resuscitate, if we repay this debt in the equal amount, we have to resuscitate them a lot more than most of them need, especially if they have pulmonary contusions, positive seatbelt sign, multiple rib fractures, flailed chests. These patients have pulmonary contusions. The wetter they are, the longer they stay on the vent, the longer they stay in the ICU, the higher their mortality. Right, Sean? Right. He's a critical care doc. So what we want to do is recognize these people and know when to cut them off. Know when to repay that debt, and know when to either stop resuscitating and maybe give them pressors if they need it, but we have to physiologically recognize that. And we have to be careful at overshoot. See the difference here? These people are never above this line. So this is the third group. This is the third group that do the same thing. They decompensate, we help them achieve hemostasis, but we don't quite get them above the line. What do I mean by that? Well, they have a blood pressure. It's 110 over 60. Their heart rate's 120. But guess what? Their base deficit is 12. Their lactate is 6. We have central circulation, and this is what I referred to before when I said that's a good broad general definition of shock, was inadequacy of the cardiovascular system. Our cardiovascular system is adequate. We have central circulation and we have microcirculation. The oxygen that we have to get to the cells to reverse shock is in the microcirculation. So we have 3 numbers over 2 numbers, the heart rate's good, but we're still in shock. So these are the people that go on to multi-organ failure and death. They stay in the unit. They stay on the ventilator. They get put on dialysis, right, CVBHD. They may end up on ECMO. So they're the patients who go, now we call this multi-organ dysfunction syndrome. But we've gotten really good at treating this because for years we've been really crappy at doing that until we understood the physiology of trauma and shock and reversing it. These are the people that, they're not in Baltimore, but they have a good grouping, center mass, right? Because nobody aims. Everybody just runs like this and shoots. Hopefully you hit the guy you're shooting at. You may hit 5 or 6 others. But if you have a good center mass and you're in class 5 shock, these are the people you see, they never get on an anaerobic. These are the people who compensate, they decompensate, and they end up in death because they're in this cellular anaerobic state that we can't reverse no matter what we do. So trauma is a fatal disease. And all this is going on in every patient that you may pick up that has a traumatic injury to one degree or another. They all fit this profile. So this is, right, this is a T-bone rollover pedestrian strut. That kid was fine. He was discharged in 24 hours. The van had one of those really big sunroofs, and it rolled over him. So he was 24-hour observation and released. So why do I have this up there? I have it up there because we get multiple casualties from that site. So this person went through the red light. Why? Because they had a syncopal episode. They're on aspirin and Plavix, and they had to run a paroxysmal AFib. They hit some guy on Coreg who's got an AICD who's driving his wife to outpatient dialysis. And they hit this young kid who was fine. So we have 4 people from an accident scene that match every one of the profiles. And it's time dependent, and we have to recognize which profile they're in so we can start their treatment. So it's dynamic, it changes. So every one of them may triage in a different way with a different treatment when they get into the trauma center. Let's talk about coagulopathy. What's coagulopathy? So it's either bad clotting or bad bleeding. So we're bleeding really, really well, or we're clotting really poorly. Well, that's coagulopathy. So if you have the choice between somebody who's coagulopathic and somebody who's clotting too much, which one would you pick? I would pick coagulopathic because it's a heck of a lot easier to treat. You know, when people are embolizing and they're thrombotic, it's really difficult to treat. So coagulopathy is a clotting disorder. So let's talk about the complexity of the patients that we see today. They're really simple in the past to take care of. So this is a scheme of the acute coagulopathy or traumatic shock. These patients have a traumatic injury. When I'm over here, I get a little too far away. But they have other diseases. Some of them have iatrogenic coagulopathy. Coumadin, aspirin, Plavix, the DOACs, right? Xarelto, Eliquis, Pradaxa, all those things that we give them, we make them coagulopathic, then they get in a wreck, and now they're really coagulopathic. So we have to recognize them as well. There's genomics of trauma. How you respond to trauma, how you respond to trauma, and how you respond to trauma, we all respond differently. You know, there's some young women who'll bump their head on a golf cart and end up on ECMO. But some guy will get shot 12 times, get 40 units of blood, and be extubated in 24 hours. We have different systemic inflammatory responses. So through the genes, how people respond. But we can't give you a card and say, I have a really high systemic inflammatory response. Good luck getting insurance even in 2017 if you have that. So we can't really label you that way, but we kind of can recognize you and know how to treat you. So these patients, well, we all know that you can't give them 2 or 3 liters of cold crystalloid from the field on the way to the hospital. Reams of data saying that that's not good. Rather have a pressure of 70 on the way in than give 2 liters of crystalloid and have a pressure of 90. Right? We know that's much worse. So we dilute them, we make them hypothermic. They're hypothermic to begin with. The guys in Iraq come into a roll 1, They're a full field pack, right? Body armor, it's 110 degrees. They come in at 33, 34 degrees centigrade. They're hypothermic from the time they get injured. It's part of the hypothalamus response to not being able to generate this thermogenic response. You stop shivering. Why? That's muscle activity to generate heat. Well, if you shut down all the flow to your muscle, you can't really shiver. So you start to get hypothermic. You can't compensate. Then what happens? Well, you enter a shock state and you get acidotic. When you're acidotic, when you get down below a pH of 7, and you have epinephrine in your hand, and you have saline in your hand, give the saline. It's just as effective, but it's cheaper. Because you don't respond to catecholamines, not even intrinsic catecholamines. So a pH less than 7 is really important. That's kind of our cutoff in trauma, where if I really need to take some time, I may give them a little bicarb at that point if they're 6'7", 6'8". We don't like to do that because it kind of masks their degree of shock, because we want to see resuscitation correct shock. We want to artificially raise it. Especially if they have traumatic brain injury as well. When you give bicarb to somebody, what happens to their CO2? It goes way up. You may have a CO2 of 25, 28, end tidal, it'll go to 50 when you give bicarb. You'll see that reaction. So that may be bad as well. And then, if we let this go on long enough, we start breaking down all the fiber and clot that we started to make. So the patients start bleeding from everywhere. You ever see someone in DIC? Right? DIC, they just bleed from everywhere. Now, we always thought that this traumatic coagulopathy and DIC were two separate things. Now we know that the fibrinolysis of trauma is a fibrinolytic variant of DIC. It's almost the same. So we've learned that over like the last year and a half. So that kind of changes the way we're looking at the early treatment. We'll talk about that in pre-hospital TXA later. So in order to survive, we have to reperfuse the microvasculature. So I'm going to throw a bunch of stuff at you right now that you may have and you may not care about. We're going to go over it really quickly. So, yes, I'm going to do this. Some of you out there are saying, oh, we've got to be kidding me, right? So the old school way of looking at this is this, right? Remember all this stuff that you learned and you had all these numbers and they were all over and you had this intrinsic and extrinsic pathway and nobody could remember it except for the exam? See, that's great because it's wrong. It is. It's wrong. We've figured this out. It's wrong. But there's an extrinsic and an intrinsic pathway. And in trauma, we deal mainly with the extrinsic, right? We have tissue injury. When we have tissue injury, this tissue factor is released into the vasculature and we activate 7 to 7A. Now, we thought that only happened because tissue factor is in tissue. But last March, in Germany, they found 9 different variants of tissue factor that circulate in our circulation all the time. So it's made us think about this differently. Cancer patients, do they bleed or do they clot really more than we want them to? Cancer patients are really hypercoagulable. Why? We found that cancer cells secrete tissue factor. All right, so they're a real different, it was a short chain tissue factor, the cancer cell. So we have this stuff going on, and this was all thought about by McFarland in 1964. He noticed these little kids running around and they had bloody noses, they didn't stop. So this was his way of explaining hemophilia A and B. But we took it an extra mile. We applied it to every damn thing. Nothing that's ever been validated for is hemophilia and Coumadin. But we use it for everything. We even use it in trauma, but we don't anymore, or shouldn't. The other thing that we also noticed was this is caused by vascular injury, and this is caused by an injury inside the vessel wall. But we know we can't separate them out anymore because they crosstalk, right? I don't know if I mentioned this before, but there are dolphins, bottlenose dolphins, that we have in the aquarium that don't produce factor 12. None. They're devoid of factor 12. They're the perfect 0 factor 12 model, but guess what? They make really strong clot and they activate 11 without factor 12. So when we study things, we study dolphin serum because we can figure out how they clot. Now, there are humans who have very little factor 12. They make really poor clot. So we can figure how the dolphins do it. We can kind of produce something to give it to people who have no factor 12 and help them clot. That's kind of going on right now. My daughter's the manager of research and special projects at the National Aquarium, so I got it in there. Little fluke blood now and then. So So this is how we clot. But there was one thing that McFarland left out of here, something called platelets. They're not in here, nowhere. But he was right in terms of getting the correctness of the importance of thrombin. And thrombin makes this big fibrin kind of clot along with factor 13, and we get that red, really thick clot, and we stop bleeding. On the other side of this, there's the anticoagulation side. Because if it wasn't for this part of it, we'd all have multiple pulmonary emboli by the time I stop yapping tonight in about an hour and a half. Maybe an hour. I'm not going to really torture you that long. So this is important because as we're clotting, we're also lysing. If you ever walk down the street and you go, ooh, that was a kind of weird pain in my chest here, you probably just flipped a little embolus, and your lungs are a perfect filtration system. Stays in there for a couple of days, this takes place, and that little clot is gone. That's why the lungs are so beautiful. We can embolize a lot of things to them. And I'm not going to say next time you have a little pain in your chest or something, don't go for an IVC filter. Or don't freak out. Don't stay up at night. You're fine. Anyway, so this is what we thought. But now we know that we have a non-binary version of this. There's not extrinsic or intrinsic. That was a 2017 joke. But anyway, so it's cellular based. And look what's in it. Platelets, right smack in the middle. So what we do is we have this tissue injury, and then we create this thrombin, and we kind of break apart this von Willebrand's factor in 8A, and we make really sticky platelets that stick together. But what we do in the meantime is we take these platelets that are about like my fist, and through 5 and 11, they open up like this, like my hand. And all those factors that we saw on the last page, they all hang out in these little pseudopods. And when that platelet activates, it makes this giant rush of thrombin. And that really starts the coagulation cascade. Much different than the intrinsic and extrinsic. Because if you look, 11's here. Well, that's part of the intrinsic, but it's in the extrinsic side of the fence. So everything crosses. And then we make fibrin. The reason why I want to show you this is because in coagulopathy and trauma, what happens is the injury inhibits all these things. They get inhibited. So we end up going the other way. You're going to get a lecture in shock, and they're going to talk about tissue plasminogen activator, TPA. We have TPA in us all the time. And it's a balance. It's inhibited. But in trauma, sometimes it's let loose to go wild, and it breaks down all the clot that we form. So what happens, and this is the last crazy slide that I'm going to show you, but this is a slide of how everything gets inhibited. So here's our endothelium, right? The cells along the vessel walls. We're in Baltimore. Not just one, we got 4. All right, so what happens when the endothelium ruptures? Well, we get what? Thrombin. It gets released crazy. But what happens away from the injury? Thrombin's going to make clot, which we don't need. You know, if you're shot 4 times in the leg and the pelvis, we don't need your lungs full of clot. You're dead. So something has to happen. So this thrombin gets picked up by this thing, and it makes a complex away from the injury. That activates something called protein C, and if you see this minus, it's inhibiting all of the things that stop us from clotting. So we want to make fibrin, but we can't. Here's TPA, and then we make plasmin, and that breaks the fibrin down, and we get something called fibrinolysis. But we can give something called tranexamic acid, TXA, which you've all heard of, and which is kind of being bandied around in a lot of places to give pre-hospital. And what that does is it blocks the conversion of plasminogen to plasmin, which stops the action of TPA, despite all this stuff trying to break down the clot that we're forming. All right, so this is your background. That's it. So this leads to shock. So this is going to be kind of the background. That was the background of everything that we're going to talk about from now on. So now you're going to be able to understand it a little better. So there's 2 types. We talked about that before, ATC and TIC, right? Acute traumatic coagulopathy and trauma-induced. 10 years ago, this is what we thought. You came in as a trauma, you got volume, we raised your blood pressure, we hemodiluted you, and then what did we do? We depleted your factors, and we made you bleed. And then we made you acidotic. Why? We gave you saline. There's nothing normal about normal saline, right? The pH is 4.5 with 154 sodium, 154 chloride. That's nowhere. That's not normal, right? There's no strong ion difference, but we gave it to everyone and we made them acidotic. We gave it cold, so we made them hypothermic. And then what we did was we made them hypertensive. And by doing all this stuff, we made them bleed. So that's what we knew 10 years ago. Now, you guys are experts. You're going to understand everything here, and it's kind of cool how it happens. So we have trauma, we enter shock, we get the inflammatory response, and by your proof, we activate our adrenal glands, right? We have the sympathetic response. And then, what happens? All that stuff starts making bad things happen. So we damage the inside lining of our blood cells, and they start leaking. We just saw protein C activation, right? All the inhibitors get inhibited. The cells that line our vasculature have these little sacs that they release, and in them is von Willebrand's factor. If there's injury, I'm going to release the stuff. I'm going to make the platelets super sticky. And it also helps white cells get to the area of injury, as well as platelets. They break down. They degrade in trauma. So our platelets become less sticky. Remember I talked about the surface layer inside our arteries? That's called the Glycocalyx. This is what it looks like. Inside of every one of your arteries is this brush border. And it's a secondary kind of layer that all our plasma proteins kind of exist in, about a third of them. And it's like Teflon. If you ever open an artery and it's real shiny and smooth, they're the plasma proteins in this surface layer. This is what happens in trauma. They break down. And the endothelial cells. Now, if we protect them with something called antithrombin 3 and steroids, which we get from autoresuscitation and adrenal activation, we self-preserve that surface layer. It's really important because once the surface layer breaks down, we start leaking. Everything we give goes into the interstitium, and we get like the Michelin Man. That's where you see the edema in some of these patients, especially septic patients. Some of those hairs in the border are made up of things called heparan sulfate. Same activity as heparin. So we start auto-heparinizing ourselves. All this stuff is just fascinating, and it goes on at the time of injury. So the time you arrive, all this stuff is rolling right along, depending on where you are in those 4 groups. So all the stuff starts happening. All the stuff that makes clot starts getting inhibited. We have TPA released, and then we start bleeding, and we start breaking down the clot. That's the way you should feel right now. If you do, you've been paying attention. Okay? So, does it matter when we have acute traumatic coagulopathy? When all this stuff's going on, does it matter? Well, they looked at it in Australia. They looked at about 772 patients. They looked back through the records. A lot of them were pretty severely injured, most of them blunt trauma like we see here. 18% in-hospital mortality, and these patients, they were patients who were admitted and they didn't have traumatic brain injury. If they had traumatic brain injury or died within 24 hours of admission, they were out of the study. Their question was, if they come in with acute traumatic coagulopathy, does it affect outcome? Just the fact that they have acute traumatic coagulopathy, nothing else. Age, type of injury, things done to those patients, intubated, chest tubes, X-laps, none of that. And what they found was, independent of how severely they were injured or how they were transfused, if they had acute traumatic coagulopathy, their odds ratio for death was almost 9-fold. What they also found was the earlier it was recognized and managed was what affected outcome. So again, identification, knowing what's happening in all these patients. So we already looked at tissue hyperperfusion. If we give patients these products early, it could be actually detrimental. If we say, he really didn't need fresh frozen plasma or thawed plasma, I gave him like 6 units, who cares? So it's not a big deal. It is a big deal because we can cause more harm with that. And you'll see people. We're going to look at hypothermia, acidosis, hemodilution, and the inflammatory response and how it affects all those things that you know already. So, what about hypothermia? At 34 degrees centigrade, that's a key temperature. Below that, remember that cascade and trauma generation and platelet activation? Below that, that stops working. So hypothermia itself is a cause for coagulopathy. Keeping the patients warm, getting to them early and warming them is really important. It really affects platelet physiology. When you get down to 32 degrees in a non-drowning scenario, your in-hospital mortality is 100%. You may live for a few weeks, but you end up with multi-organ failure and a lot of things. Non-drowning. In a drowning scenario, if you rewarm those patients, they have a better shot. Why? Well, because when you're really cold, what happens? Everything clamps down. All the small vessels that we're trying to get oxygen and blood and all those things to, they close down. The cells die of an anoxic death, even though the patient's intubated, getting 100% oxygen, has a good cardiac output. That vasoconstriction is really going to avoid or inhibit us from getting oxygen to where we need it. So the acidosis worsens, and it's that vicious cycle. Below a pH of 7.4, the platelets lose the ability to change from this to this. So all this stuff is going on. Calcium binding sites, we need calcium. We know that when patients come in. When you bring a patient into a trauma center, they're hypocalcemic, every darn one of them. They probably, normal ionized calcium is 1.2, 1.15. They're all 0.7, 0.6, 0.5. Why? They need it for cofactors. If you look back at that cascade, calcium is needed in a lot of those factors. So we start using it up because we're trying to clot. At a pH of 7.1, basically hardly anything works. So you have to resuscitate, right? We can't make clot. So acidotic, hypothermic, we saw that in the beginning. This is what's happening. What about hemodilution? You give a bunch of crystalloids, we dilute factors. We used to give colloids. Remember Hespan and Hextend and all those things that got pulled from the market? They caused a breakdown of fibrin. They were pro-fibrinolytic. In the military, they still give Hextend because it's what you can hump out there. Now, with the new remote damage control resuscitation protocols, we're trying to get them whole blood early. We used to give chest tube blood. We don't do that anymore. What about the inflammatory response? Right? Endothelial activation. We saw the cells that line the vessels. They start breaking down. They separate. And we saw this activated protein C. It inhibits everything. So we degrade the lining of all of our vessels. A lot of stuff's happening. And this may be in 20 minutes. You may not get there for 30. So by the time you get there, a lot of stuff is going on already. So it's absolutely more imperative. So I guess you have to be really cool to figure out what the bill on a hat is supposed to be used for. The Cubs fans understand. Oh, he is a Cubs fan. Oh, that's why he's sitting at the end. So let's talk about ATLS. You're going out there and you're going to look at these patients and say, okay, what class of shock are they in? Well, we know, and these are old references back to 2010, that heart rate, blood pressure, respiratory rate, GCS, they exist, but they overlap and they're intertwined. They're not these just elements of classes of shock. And it's really important for us to recognize that. Another paper saying that in hypovolemic shock, ATLS classification really doesn't seem to affect the clinical scenario. Why? Well, if you look at classes of shock, and we know that patients are on multiple drugs now, right? So somebody is not going to have a heart rate of 120 if they're beta block. They're just not. They may be hypotensive, but they won't have a heart rate of 120. However, what they will show you is a decreased pulse pressure. That's key. So the lower, the smaller the pulse pressure when you arrive and you're going to induce someone, right, who has traumatic injury and you're going to do an RSI on. If their blood pressure is 100 over 80, or if it's 80 over 40, give me the 80 over 40. Because that means they still have vascular compliance, but they're hypovolemic. The other is hypovolemic and has no more vascular compliance. That 100 over 80 means they're clamped down. The difference between diastolic and systolic vascular compliance is nothing. So you give them even an RSI dose of ketamine. I've seen those people VF. So you really have to, and as we go out to compensated class 3, pulse pressure is markedly decreased. If you're in the TRU and somebody comes in and they're in a lot of pain and their blood pressure is 90/70, the nurses will give them 25 mics of fentanyl because they know if they give them 50 or 100, hard and fast. I've seen it happen. So pulse pressure is the key, especially with an elevated heart rate. So that's one thing I wanted to point out there. The other thing that we use as predictors, but you can use in the field just as a red light, is something that we use is the assessment of blood consumption, the ABC score. This was Brian Cotton in Houston. And what he did, you're not using ultrasound, so you don't know if the patients have a positive fast. But if they have a penetrating torso trauma, I'd take the trauma and the points to tell you that they probably had a positive fast, an ultrasound. They probably have blood in their belly or blood in their chest. So if they have that, they have a heart rate 120 or greater and a blood pressure of 90 or less, they have about an 88% chance, that's all 4, of needing a master transfusion, meaning that these people are in shock. So if they have 2 of those, it's about 84% chance that they'll need, when they get to the hospital, master transfusion protocol, meaning high ratio. So if they have a high heart rate, a low blood pressure, and they have a torso trauma, get them somewhere fast. And what would be nice is if we could give you that responsibility to say, I got an ABC score of 4 or an ABC score of 3 with a variable because you don't have ultrasound. That would help us. That's why we developed the shock index. The shock index and delta shock index is really important because you're really telling us, right? You got a low blood pressure and a high heart rate. That's half of the ABC score. And if you got a penetrating trauma, you got about an 87% chance if you have somebody who has to come in quickly and need a lot of blood and blood products. So that's our way of predicting it when they get there, but you have a way of doing that in the field, and that's why we'll take a look at blood shock index in a little bit. If you have all 4 of those, you have almost 100% chance of needing or being coagulopathic. And we'll skip that last one. So what if we're wrong? Just say, all right, let's get some plasma. Let's give this guy some plasma because his blood pressure is a little low. So this was a study. It was done back in 2010, but again, it's old, but they were kind of these landmark studies. Kostas Dimitriadis, Kenji Inaba. Kenji was in the Air Force at the time out in LA County. And who else? Lauren Blackburn. Lauren Blackburn was Air Force as well. So they looked at 1,700 patients who received at least 1 unit of blood. What they found was if they got plasma, it didn't really help them if they didn't need a master transfusion, meaning more than 10 units in the first 24 hours. So they then looked at the people who got plasma. So they looked at people who got 1 unit of blood, and then they took another little group out of that, and they said, all right, who got 1 unit of blood? Or who got blood and more plasma. So they kind of stratified them into how much plasma they got, and they kind of really didn't need it. So they looked at the complication rates. And as the volume of plasma went up, and you got up to 6 units, their lung injury went up almost 3-fold. And then when they got greater than 6 units, ARDS, multi-organ failure, which we saw in those patients who were not resuscitated well, pneumonia and sepsis caused by plasma when they didn't need it. So calling this correctly is really important. It's important to recognize. So if we get that information, and you guys tell us that we have, heart rate greater than 120, you may not know that you're giving us the ABC score, but you are. So this helps us predict. So rapid diagnosis. Here's what we're going to do in 5 minutes. We're going to go for a break, then I'll come back for like 20 and we'll finish up. We'll talk more clinical after that. So we have a rapid diagnosis. We know that the target is that surface layer that lines all of our arteries. That's the primary target, because when that breaks down, all hell breaks loose. Seriously. It begins at the time of injury. What does it look like? Let me show you. This is a little diagram. So here's the vascular lumen. This is without it. If we look at the endothelial surface layer, this is the glycocalyx, and that's the surface layer. So it's a secondary sealant, so that anything that is cellular or anything that's the size of plasma can't leak out. But we saw what happens when we undergo trauma. It breaks down. So we start leaking in between the cells. Does it really happen? This is a rat study, right? And this is rats that got shocked. This is the thickness of that glycocalyx. So they got cut but didn't get shocked. They got shocked. They got crystalloid. And these rats got their plasma back. So the thickness actually was maintained when they got their plasma back. Look at when they got crystalloid. What about regenerating it? So they look at this messenger RNA and they look at the sham shock. This was their maintenance. These were the shock rodents. These were the rodents that got crystalloid. It's better to leave the rodents in shock and not give them a drop of crystalloid when they're in shock than it is to try and resuscitate them with a couple bags of crystalloid. Right? Same in humans. And if they got plasma back, they started regenerating this. If we look at it under electron microscopy and we really blow it up, these are cells. These are endothelial cells, all stuck together. And these are the rodents who got shocked. Look at how the gap grew, that little white bar. And when they got plasma back, that bar shrunk. It closed the gap. So by correctly resuscitating these rodents early, I'm not going to say you got to make a run and go pick up a couple of rats, but we can extrapolate this to humans. It does happen. After this, we're going to go for a break. And I want to show you something that's really cool and that it really exists and what we can measure now. And it may be in your future. So this is the amount of complications somebody gets. These are people who don't have enough volume. So they have cells, but they don't have enough volume to get the cells through the vessels. These are people who have too much volume and can't get the oxygen through the tissues. So they have the higher complication rates. The patients with the correct fluid volume, the correct oxygen carrying capacity, have the fewest complications, right? So the microcirculation is the destination. We talked about oxygen transport, right? Too little is defined in a little bit of flow in the microcirculation. Too much, and we increase the distance for oxygen to travel, can't get it to the mitochondria, can't make that ATP. If we optimize, then the red blood cells can flow, they can line up. Now red blood cells are bigger than the capillaries. They have to do this to get through. If they are anaerobic, they can't do that anymore. And they also stick. So what do they do? They start clogging up all these vessels. And guess what? No oxygen. Anaerobic metabolism shock. So here's that mitochondria. Here's the red blood cell. Here's a picture of microcirculation. So this is normal microcirculation. See all the stippling? The stippling is there's not enough volume. So things are starting to get caught in the microcirculation. Here's another picture of microcirculation, and this is normal, and look at all those small vessels. This is a picture of too much volume. We've closed them because all that volume leaked in and closed them from the outside. On the couch in my office at Shock Trauma, with a probe the size of this pen, one of my partners put it under his tongue. And we filmed this. Individual cells through the microcirculation. You can see here, there's white cells. Here, where there's no cells, that's plasma. It's called plasma gaps. So this is normal microcirculation. It exists. All the stuff I've been throwing at you is real. Now, the computer program, what it does is it tags all the vessels, and it gives us a size, and it gives us a flow rate. So if we're resuscitating correctly, we start seeing more vessels come in. We see a better flow rate. We see more vessels pop up. If we're over resuscitating, we're losing vessels, and we see the flow rate slow down. So by computer programming, we can actually look at it. Now, this is normal. What about somebody in sepsis? Look at the difference between that and this. This is a septic model. Some of them have normal flow. Some of them have no flow, very sluggish flow. This is in a kind of a view of about 15 to 20 microns. So you can imagine what's happening in the whole organism in sepsis. This is just under the tongue of actually a pig. So this is why we have job security, and then we'll go for break. Well, might as well look, right? It's not that bad. Well, you pick up your gun, of course. Damn. There's his hat. So looking in slow motion, watch the gun kick. Kicks away. He's a very lucky man. They kicked away. Anyway. Okay. So why don't you take a break, and then we'll finish up. We're going to talk a little bit about the military and pre-hospital. You want me to start again? I'm not. Don't worry. They were exactly the same. And then we thought, could we have been wrong all these years? We've been given 1 to 1 to 1. And now we look at this and it's 1 to 1 to 2, and the mortality is no different. But what we did find is this is the 1 to 1 to 2 group, and this is the 1 to 1 to 1 group. Their shading crosses here, and if we bring it up, you can see that the significance, there isn't any between the two, except for right here. Between the 2.6 and the 2.9 hour mark is the median time where people die of hemorrhagic shock. The only time that the ratios were separated was right there. So that time between 2 and 3 hours was key. What happens after 3 hours? What happens after 3 hours if you give people TXA? They die. So something else happens out there. That 2 to 3 hour mark was crucial. Component therapy, high ratio, that's the time to save people. So getting them to a trauma center when they have those indicators for massive transfusion, you know now, to reverse that anaerobic metabolism is absolutely key. $40 million DOD grant to do this. And they thought, this is garbage. But then when we analyzed it, we found it really wasn't. It was really key. Why don't we give red cells and crystalloid? Why is crystalloid bad? Because when we give, if we look at multi-organ failure, right? Those people on dialysis, people on the ventilator, people with liver failure. If we give red cells and crystalloid, if we give 1.5 cc's of crystalloid for every cc of red cell, and we look at things like multi-organ failure, lung injury, right? Abdominal compartment syndrome. What happens when you give a lot of volume? The intestines, they get edematous. When the intestines get edematous, remember last time I talked, we said all the compartments are connected, right? The diaphragm gets pushed up. It's harder to bag them. If they have traumatic brain injury, their ICPs go up and plateau. All because why? We give too much crystalloid. It's kind of your answer that you asked me about when we give too much crystalloid in patients with lung injury, that it breaks down that surface layer. And even when and early is what we knew before, and late is what we know now, even now we're still doing that in some institutions, and there's still an increase in lung injury and abdominal compartment syndrome, which is, abdominal compartment syndrome is huge. So when people get injured, they lose blood, they need blood. They don't need crystalloid. So they need to get back what they lost. Pre-hospital, these two studies. Pre-hospital administration of TXA is about 458 patients. This is in critical care, 2016. This is the CalPAT study, the California Pre-Hospital Administration of TXA. And that study was about 258 patients in each arm. But what they each found, they found something different than that other endotheliopathy study that said it didn't matter if you gave TXA, the patient still broke down their glycocalyx. These two studies show that if you get TXA, the time to death is prolonged, and the amount of blood and blood products you give them is lessened, and their survival is increased. So this is 1 gram of TXA over 10 minutes and 100 cc's of saline. That's what they were giving in both these studies. So in terms of the actual surface layer, it didn't matter, but in terms of blood and blood products, somehow it does. So it may just stabilize the clot that they're forming. So let's talk about how does this work with the military and us, and what does it really mean? And this is where we're going to finish. So there's something called THOR, Trauma Hemostasis and Oxygenation Research. It was founded back in 2011-12. Right now there's 191 people as members. I'm one of them. 20 countries. Last year we had 115 people there. It's invitation only. It's not a conference where you go, oh, I'm going to go to Norway. It's a working conference and working groups of people who kind of communicate with each other. The founding members are 3 people. He's the commander of the Norwegian Special Ops. Phil Spinella was one of Johns Hopkins guys in the military, and Tor Hervig is a blood banker, and they're in Bergen, Norway. So we meet outside of Bergen. Phil is in Wash U in St. Louis. So we put together this group of researchers around the world for one common purpose, and that was to educate and improve outcomes. A multidisciplinary group to save soldiers' lives who are dying of hemorrhagic shock, who shouldn't be dying of hemorrhagic shock. There was something that we could do pre-hospital and intra-hospital, but primarily pre-hospital. This is pre-hospital austere environments. So our mission was research and collaboration. What we do in the labs, what we do in the medical centers, what we do here, and what they do out there in austere environments with night vision goggles, we're going to put that together. And our goal is to prevent soldiers who are DOWs, died of wounds, primarily from penetrating torso, non-compressible, and junctional hemorrhage. If you have an injury in your limbs, tourniquet, no-brainer. Junctional torso hemorrhage, 4 hours to medevac, you got a problem on your hands, especially at night. So that was our goal. We were going to prevent this from happening. Didn't want to see that happening anymore when they could be preventable. So what we did was we put a group together, and this is simulation. This is not. And we wanted to decrease these salvageable fatalities due to hemorrhage. 80% of them were potentially salvageable through research, training, education to the end user, who a corpsman in the field with night vision goggles, who goes to someone's side in an austere environment, not dragging him to safety. I mean, people are still trying to take your head off while you're out there, right? So talk about time, not waiting till they evac him, but time to get him to safety and get him whole blood immediately. So that is if we can do it safely, and yes, we can. We have a lot of things now that we're using that we can get this done safely. The special ops guys in the Norwegian Special Ops Command have their blood type tattooed behind their ear. They don't wear dog tags. And it's important that they treat themselves out there, because you know why? 90% of the time, we don't know where they are. Their missions are to a point where I'll see you at some time, make contact. So they're on their own. Now, they don't have it tattooed on their arm because they may not have the arm. They don't wear dog tags. That's a target. They don't have a head. They don't need a transfusion. So basically, it's that simple. So what we do is they make us go here every year. I tell my wife I'm going to work. So the whole hotel, the whole resort is us, 115 members plus. And we all meet. We don't wear these jerky shirts the whole time. This is just our picture. This is actually Gene Moore. Here's Phil Spinella. Gear is up here. He's making me laugh because he always does. That's me, the guy with the square head. And so we take this picture, and this is after we've been working for a long time. So it's hard work in faraway places. So what we do is, this is 4:30 in the morning. Here's a group of us. Here's gear. These guys are all special ops, med support. He's a rescue diver for the UK. And what we did was, we sat and we talked. We discussed and we discussed and we discussed. And Andre Kapp, the guy holding this, is the guy in ISR working on platelets and whole blood. And I was yapping for a couple hours, and he wrote all this down. 4:30 in the morning, he looked at it and he said, "We got it." So got what? He goes, "We just wrote the 75th Regiment Remote Damage Control Resuscitation Protocol. We just rewrote it." And at 7:30, we showered. We were back in that at 7:30 to present what we did. So we'll take a look at that in a second. So it is a working meeting. Actually, the person at the desk took this picture because the whole pub was closed. We had no idea that everything was done, cleaned. We were just sitting there working. So this is something we just got done doing. There's other people involved in this, but we were kind of the main three contributors here. And what we wanted to see was that if we could take something as simple as this, and by using tissue oximetry, and I'll place it on my greater thenar eminence, by using this, if we could predict life-saving interventions, intubation, chest tubes, XLAPS, mortality, just by putting this on someone. So what we did was we looked at ISTAT, and we did venous gases, glucose, and then this STO2 monitor. And we were looking for the ability to predict. To predict what? To predict the efficiency of microcirculation. We saw that already. Now, what about survival? Here's mortality and morbidity and survival. And this is survival and time to correct what? Hypoperfusion. We talked about that, right? That's shock. So if we correct it in 0 to 6 hours, that survival is 100%. As we reach that 24-hour mark, it drops to 57, but look what also increases. Multi-system organ failure, respiratory complications. So everything that we talked about really happens. So right now, my STO2 is 87%. A little high. So what I'm doing is probably by yapping so much, taking in a lot of oxygen, so I'm not dumping it at my tissues. I'm not utilizing a lot. So what's back here is 84%. So hemorrhage control is important, especially in torso hemorrhage, right? So the first thing that happens is we drop that flow to the microcirculation. This starts to fall early. It may be 60 or 50 when they put it on. Line placement. Well, in most of the soldiers, they have the body armor, so we try to get a peripheral line. If not, sternal IO. That's what we use. 5-prong sternal IO, no drill, no nothing, one bang, it's in, central. The marrow in the sternum is red to the day you die. I don't care if you're 100 when you die. The marrow in long bones, yellow by the time you're 30. So your vasculature, your circulation in the marrow in peripheral long bones is really less than central. And you can give a unit of whole blood. I've seen it. A unit of whole blood hanging 4 minutes in to one of these special ops guys. One of these knuckleheads that they banged it into his sternum while he was just hanging out. And remote damage control resuscitation and pain management, right? We manage pain with ketamine. And how do you know they have enough ketamine? They start getting nystagmus. When they start getting nystagmus, you stop giving the ketamine. Because why? You want them to keep breathing. You can't put a tube in them and call somebody to bag them for 20 hours or 14 hours. So what do? Well, we look at their degree of shock. This is what we wrote that night. Any signs of hemorrhage, 1+ amputation, blunt penetrating trauma, we talked about that ABC score. So what do? They get an initial life-saving intervention. They call for fresh whole blood. Someone in that group, that whatever they call the special ops guys when they're going along, maybe just 4 of them, right? They know the blood type and they know who's available for each one of them. They get IO access, they get 1 dose of TXA, and then they start talking to them. If their blood pressure is 70 and they're still talking, they got brain perfusion. And then what they do is they take a finger stick for lactate and look at their blood pressure and their pulse rate. Right, we talked about a high pulse rate, a low blood pressure, that was the ABC score, but here it's a shock index. If their venous lactate is greater than 5 and their shock index is greater than 1, meaning that they have a high pulse rate and a low blood pressure, they get a unit of whole blood. And then what they do is they reassess. If the shock index is less than 1, they continue monitoring. But after they get this and they reassess, there's a chance that the lactate may bump up. But their pulse rate and blood pressure are still good. Their shock index is good. What does that mean? That means that we give them whole blood and we're washing the lactate out of the periphery. We're doing a good job. If their shock index is worsened, they get another unit of whole blood, and then we go through the whole thing again. This is what we did that night. They didn't have this section. They just kept giving fresh whole blood. So drinking some beer and some wine and talking a lot and discussing and having a purpose really helps. This went up the line in the Pentagon already. It's been approved. So whole blood is important. If you have the option of eating an apple or taking all these things, right, that are a component of what an apple gives you, this is cheaper. It's a lot better, easier to carry than all this stuff. And it's readily available. And guess what? That skin is waterproof. So is ours. If you have whole blood, I don't have to keep it cold. I don't have to worry about typing crossing. I don't have to worry about bagging it. You're a waterproof container, and it goes along with you. So that's the other good thing. So we wrote this article in 2015 in Journal of Trauma Acute Care Medicine about time to get moving with whole blood. You know, we had all the evidence there, and we kind of pushed it forward. So 1,500 die of hemorrhage every year, about 28%. We could reduce that by 50% range over one conflict. And if 50% of this is due to blood, then we need to get that moving forward, right? So it could save hundreds of lives, not only in the military, but in civilian as well. Because when you take whole blood and you break it down to the components, we're losing a lot of things like things that immunomodulate us, things that cause this decrease in the inflammatory response that help us clot even sooner. So if you give 1 unit of whole blood, you may not need 20 units of component therapy, because it's that effective in treating coagulopathy. What does it mean to us? Well, when you give whole blood, the total volume is less, the hematocrit is higher, the platelet count is significantly higher, and the coagulation factor activity is higher. So we have whole blood that's leukocyte reduced. We store it between 1 and 6 degrees. The problem is the platelets have to be stored at 22, so we have to take them out. This is what I was talking about. So right now they're working in the ISR, and what happens when we get platelets down to 4 degrees in the presence of fibrin? The platelets aggregate. They become a clump. So what they're working on now is to shut those fibrin receptors off in platelets when they're cooled and turn them on when we're at body temperature. If we can do that, we can store whole blood for 3 weeks at 4 degrees C, which we can't do right now. So that's very close. And if we can do that, we may be seeing pre-hospital whole blood in civilian populations. And it decreases mortality. So what does that mean to us? One of the guys in our group is Steve Williams, not Tiger Woods' caddy. Steve Williams, he's the cruise director for Norwegian Cruise Line. When you go on this cruise and you're in the Caribbean and somebody needs a massive transfusion, guess where the blood bank is? There isn't one. But guess what they do now? They have a protocol to call people to donate fresh whole blood. We have cards that we can tell your blood type, your RH, and your K antigens. And also, it's another card produced by Grifold, related diseases, HIV, Hep C, Hep B. So we haven't come up with non-A, non-B yet, but we have that. So they'll call you down. As soon as you go on one of these cruises, they'll ask you if you have a blood donor card. And if you do, they want you to register. Why do you think that's necessary on cruises? Well, Grandpa's got esophageal varices and he can blow any time now, so let's take him on a cruise. And that's what happens. Grandpa usually blows when they're on a cruise, and then they need a massive transfusion and have to helicopter them out. Or somebody with liver failure, right? They're, you know, high failing with their second transplant, they want to take them on a cruise again. They become coagulopathic. It happens more times than you think. Even like prepartum hemorrhage. Women are 6 to 8 months pregnant and they miscarry and they have this bleeding diaphysis. They go into DIC. They see that a lot as well. Out in the Mayo Clinic, they have to travel so far to get patients in medevac. They have to go fixed wing. Could be 2-3 hours. And in the U.S., not every hospital has a blood bank. They have a regional blood bank, and they have to call to get the blood. So when they arrive and they fly back and put them on a helicopter to take them to Mayo, they are the regional blood bank when they arrive. So it's really important. One other person that we had with us, they're in a small island off of Quebec, and it's about a 3-hour helicopter ride. They're a fishing island. They only have enough blood for 1 blood volume, for 1/2 of a blood volume. So what they did by coming to Thor was we got them to initiate this donor program where then they have fresh whole blood available. And all those small islands, everyone knows everyone else and what they've been doing, so the blood's usually pretty clean. So to conclude, we know how to identify injury, and we understand the pathophysiology now of traumatic injury and when it starts, at the time of the injury. We know the relationship of tissue injury and shock, right? The more tissue injury, that more thrombin is produced, the more we clot. But if we have shock and hypoperfusion, we start breaking it down and become coagulopathic. We saw a little glimpse into the future of pre-hospital identification of endotheliopathy, the breakdown of that surface layer. And if we could target that in the very near future, that may be saving lives very early on, because we know it happens at the time of injury. The earlier we go aerobic with the patients, the better they survive. And we know that microcirculation is the way we get oxygen to the cells, the way we make ATP, and we keep the engine running. And with that, does anyone know where this is? I'm still 84%. Here, you want to pass this around? I'm walking around with this like an idiot. Now, there's a tissue hemoglobin index. That has nothing to do with your hemoglobin. That just is the, it's an index of flow and the near infrared. So if you, in order to put this on, backwards.
If I should put it on the right way, huh?
So this has to line up with your greater thenar eminence. And if you want to really play with it, have one of your buddies lean on your ulnar and radial artery for about a minute and then release it. You'll see this drop, and then when you're at 95, because you have this hyperemic response. He's going to do it. Call out the numbers. Anyone know where this is? Close? Yeah, it is New England. It's Boston. It's Quincy, Mass. It's called Peacefield. Peacefield was the home of John Adams. So John Adams, he died in 1826 on the 4th of July, the 50th anniversary of the signing of the Declaration of Independence. And 45 minutes after he died, Thomas Jefferson died on the same day. One of his last words was, actually, Jefferson died 45 minutes before him. He was the last survivor of the signers of Declaration, the 50th anniversary. His last words were, "And Jefferson survives me." But nothing was trending on Twitter back then, so he didn't know. So he thought that Thomas Jefferson, and they were kind of enemies, but they got really close at the end. So there was a Harvard grad who followed him around for the last year of his life. The Harvard grad's name was Ralph Waldo Emerson. And that was his job for 1 year. And when Ralph Waldo Emerson was asked at the end of his last year of his life, John Adams, what was the most remarkable thing, what's the most memorable thing that you remember Adams saying in that last year? And it was this: "I wish to God there were more ambition in the country. By that I mean the ambition of the laudable kind. Wouldn't it be great to reinstate, through what we do as parents, grandparents, teachers, legislators, and students," right? You're all students. "The noble ambition to excel." And that's key. Whatever you do it to the point where you excel, no matter what you do. It's really important. We've lost that. It's good enough should never be in your vocabulary, right? And you know what? It's not, because you're all here listening to me. You must have some kind of ambition. These guys, his hand's going to fall off. We're going to have to do an embolectomy here. Where is he? He's at 50. All right, now let it go and watch what happens. So he's at 50. It's down to 49. So now he has flow. So now it should jump up actually into the 90s, because you have this hyperemic response. Because of the acidosis, you've dilated to compensate. So you can see that it really worked with decreased flow and increased flow. Can you give me a thumbs up? Okay, still works. Okay. So with that, I say thank you. And these little girls grow up to be big girls. So that's my email address. Again, I have a Dropbox account with thousands of references. Send me that email. Tell me you were here. I will link you with that Dropbox account. You can have that as a library. And this lecture is in it, and many others. And a lot of the pre-hospital stuff is in it. So please, I'll share it with you. No charge. One of the few things in this world that is no charge. With that, I'm going to say thank you.